part 2 of the HHS overview. I can't see what your name says there.
Ivy. Easy. Just stick to my first name. It's easy.
Go right ahead.
So I'm from the Office of Tribal Affairs at the Health Resources and Services Administration, and I know it's going to be a little hard to get back into the 101 sessions after the swearing in, but I will be short and sweet, and you can save your big questions for our leadership who will be here tomorrow. So one thing about HRSA, our name kind of talks about what we do. We're the Health Resources and Services Administration. So a lot of what we do is provide resources and services. What that is on is a little bit unclear because we provide so many. But our mission is to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. And I'm glad we have the opportunity today to share a little bit about what HRSA does because we do have such a wide range of programs. We have over 90 programs and 3,000 grantees. HRSA provides tens of millions of Americans with quality, affordable health care and other services. HRSA's vital work expands access to health care services in the communities that need them the most, including people living with HIV/AIDS, pregnant people, mothers and families, and otherwise unable to access quality health care. This includes primary care provided by HRSA-supported health centers. Our health center program is our largest program, and health professionals who receive HRSA scholarships or loan repayment assistance, which I'll get into a little bit later. HRSA-funded prenatal and postnatal care, newborn and other medical screenings, voluntary home visits, and other maternal and child health services, HIV care and treatment services, rural primary care and substance use treatment programs, discounted prescription drugs, organ and blood stem cell donation, transplants, and other programs like the poison control hotline. So we, as you can see, we have a wide variety of programs. This is just a breakdown of our appropriations, and this will be included in your slides as a reference, but our leadership who will be here tomorrow will go over this in greater detail. Carol Johnson is our administrator. She joined HRSA in January of 2021. And she has 3 priorities for the agency that aligns with departmental priorities. These are behavioral health, health workforce, and maternal health. HRSA's behavioral health efforts are actually integrated into other programs, such as primary care through our health center program, expanding access to treatment for substance use disorder, including opioids, through our rural health Office of Rural Health, HRSA's Pediatric Mental Health Care Access Program through our Maternal and Child Health Bureau, and those are just a few of what we're doing on the behavioral health front. When it comes to maternal health, we do a couple of things that are just strictly for maternal health, and that one of those things is we facilitate the Secretary's Advisory Committee on Infant and Maternal Mortality. Last year's meeting was held in Indian country, and we received a lot of recommendations on how to improve birth outcomes, and this year those recommendations were shared with the Secretary. And we also launched a maternal health hotline last year on Mother's Day, and I know the number's not listed here, but the number is 1-833-9-HELP, the number 4, moms. and it provides 24/7 free confidential support before, during, and after pregnancy, and it provides access to counselors and referrals to support groups. So we're still trying to get the word out about that to help a lot of young mothers. Continuing with our maternal and child health focus, so a lot of what our Bureau does is to provide block grants to states, and they also have the Healthy Start program, which I think some of you are familiar with. But we also, in conjunction with our sister agency, the Administration for Children and Families, we administer the Maternal, Infant, and Early Childhood Home Visiting Program. So HRSA administers a program for most of the population, and ACF administers the program for tribal communities. Another opportunity, another program that I want to tell you about that's not listed here is the Pediatric Mental Health Care Access Program. And this is one of those that I mentioned is how we're doing some of our behavioral health work. So the Pediatric Mental Health Care Access Program uses telehealth to promote behavioral health integration into pediatric primary care. And this program actually has two tribal grantees, the Red Lake Band of Chippewa Indians in Minnesota and the Chickasaw Nation in Oklahoma. So since the initial launch of that program, we've received more funding for it. And the applications opened on Tuesday, so they're open now. And before the Bureau put out this notice of funding opportunity, we had a listening session, and a lot of the comments that we received from tribal leaders were incorporated into the notice of funding opportunity. So we really urge you to apply for this opportunity. And if you need more information, please, feel free to reach out to me. We're also having an applicant webinar for potential applicants that's going to take place on April 26th. And we should have a Dear Tribal Leader letter out on that soon, too. And then moving on to our health workforce, this is something that we are proud of and what Indian country is really interested in. And we are trying to strengthen the health workforce and connect skilled healthcare providers to communities in needs. And we have over 50 programs in our Bureau of Health Workforce. And we grow the workforce by supporting community-based training and encouraging clinicians to work in high-need areas. And then we impact careers from education and training to service in the community to continuing education. And here is a breakdown of our programs. Our 50-plus health profession programs can be separated into these 10 categories that you see here, ranging from the educational pipeline programs to key primary care fields, loans and scholarships, programs, and provider resiliency. So these programs aim to increase the number of health care providers in underserved areas. And together, BHW's programs have the potential to impact every aspect of a health professional's career. So we are an agency that provides funding through grants, and our Bureau of Health Workforce actually has a set aside for National Health Service Corps applicants who will serve in ITU facilities. So for the past 3 years, we've received a set aside of $15 million, and everyone who has applied has received an award. And this year we received $15.6 million. So we're glad that that number is growing, and we encourage you all to please tell the students and those health professionals that you know of who are interested in some loan repayment programs to seek out HRSA funding, whether it's through the set-aside or if it's to tap into the other programs. We know that IHS has loan repayment programs as well, and a lot of students that we talk to say, "Oh, I'm going to get IHS funding," but we also have funding available, so we want them to make use of our funding as well. So our National Health Service Corps, I think it was due to the pandemic, we were able to provide the most number of scholarships and loan repayments that we ever have. We currently have 24,500 clinicians working in exchange for loan repayments in high-need areas. This is the highest number ever. Moving on very quickly to the Health Center program. This is HRSA's largest funded program. We have 1,400 health centers, and we have 14,000 service delivery sites in every U.S. state, territory, and the District of Columbia. Currently, we have 35 duly funded IHS and HRSA health centers. Moving on to rural health. So our Federal Office of Rural Health sounds really nice that they should be providing a lot of funds to rural health, but they, for some reason, do not receive as much funding as a lot of our other bureaus. And I think this is because it's more of a policy-based office, but we do have some programs on rural communities, opioid response program, and in 2022 we had $130 million in that program, and it served 1,800 counties. And HRSA's rural behavioral health programs have served more than 2 million residents. I know Councilman Lewis, you had mentioned having a substance abuse summit coming up. So, if you'd share that information with me, I would like to share it with our Office of Rural Health Policy. They've been out to Indian Country, and I think they'll be interested in attending that as well. And closing off a little bit here, I'd like to tell you about our Tribal Advisory Council. Our last meeting was held in Tahlequah, Oklahoma. We are seeking to fill 3 positions, delegate positions, for the California, Bemidji, and Phoenix areas. So if you know of anyone who is available to be a part of our Tribal Advisory Council, we would welcome them to join us. And lastly, this is our Office of Tribal Affairs webpage. We are doing a revamp with that, and we have Dear Tribal Leader letters that are up to date on there, and here's our email address, and please feel free to contact us with any questions that you may have. And this is our HRSA contact information. And now, while I'm passing it over to my colleague at NIH, let me know if you have any questions.
This is Nicholas. I just want to say I will get you that information and follow up with you, and I appreciate all the work that HRSA does. I think from a tribal leader standpoint, I don't think people realize how much impact HRSA can help with the tribes, and so I always appreciate the advocacy and trying to help every way we can, but I will get you the information and look forward to more discussions on the fentanyl summit that we're working on.
Thank you.
Sorry. Well, good afternoon. I'm Robin Kawazoy. I'm the Acting Director of the Tribal Health Research Office at NIH. I'm also the Deputy Director of the division with the longest name ever, the Division of Program Coordination, Planning, and Strategic Initiatives in the Office of the Director at NIH. And I really appreciate the opportunity to meet with you today and tell you a little bit about NIH. As you may know, NIH is the largest public funder of biomedical and behavioral research in the world. Our mission is to seek fundamental knowledge about the nature and behavior of living systems and to apply that knowledge to enhance health, lengthen life, and reduce illness and disability. We do that in several ways through research, both intramural research in our own laboratories and extramural research, that is the support of scientists who are in universities, academic medical centers, and other institutions, and that's through a peer review process that I'll talk a little bit about a bit later. We also train research investigators, and we communicate information about health and medicine. The NIH is composed of 27 institutes and centers, each of which has its own mission and budget. There's also the Office of the Director, which is at the top of this chart. So, getting to the Tribal Health Research Office, the THRO, as it's also referred to, has been in existence for 8 years. It was established in 2015. It really serves as a coordinating hub for research on American Indians and Alaska Natives. It staffs the NIH Tribal Advisory Committee. We also have an internal coordinating committee, the Tribal Health Research Coordinating Committee. We're working very hard to try and improve our processes for gaining meaningful input from tribes through consultation. We developed through the THRO the NIH Tribal Consultation Policy that was released in 2022. We've helped organize a variety of consultations on different programs, and you'll find information about that on our website. And probably most exciting is there's going to be a new director of the Tribal Health Research Office. Her name is Karina Walters. She's at the University of Washington at Seattle. She's a very experienced researcher. She's done research for over 28 years. She has multiple NIH grants. I think she will really energize the program, and we're all looking forward to her coming here. And she actually starts on Monday, April 24th. So getting back to the agency level just a little bit, the NIH budget is over $47 billion in FY23. 84% of that budget goes to support extramural research, the research in academic medical centers and other institutions. 10% of our budget is in our own, used in our own laboratories, and then the remaining 6% is for research support, administrative and operational activities, and construction and maintenance activities. So peer review that I mentioned earlier, we have a competitive process for peer review. It's depicted on this slide. It starts with a researcher submitting an application to NIH, which is assigned to the appropriate NIH review committee. It is comprised indeed of peers. They review each application for scientific and technical merit, and they assign a score to that. All of that information is shared with the appropriate National Advisory Council of the Funding Institute Center or OD office. They also review, for a different purpose, really for priorities and for policy considerations, and they make recommendations to the Institute and Center or OD office director, who ultimately makes the funding decisions. So a little bit about NIH's American Indian and Alaska Native research portfolio, which is trending upward. I know it could be upward more. In FY 2018, the investment in AI and AN research was about $180 million. In FY 22, that had increased to $330 million. And this year, we anticipate spending, and it is an estimate at this point, $347 million. So we are working very hard to try and expand that, and I think with Karina Walters coming, hopefully we'll see increases in that. So one of the questions we get asked, certainly by our own Tribal Advisory Committee, is, so how do I find more information other than these kind of larger budget kind of figures about how much you support? What do you support? And NIH works hard to try and make that information easily accessible and certainly publicly accessible through an online portfolio tool. And it's at report.nih.gov. You can see funding by state, funding by individual institute, center, or office. You can then click on funding per year. If you click on like the funding in FY22 that's at the top, the $330 million, it will get you an individual project list. And then if you click on the individual project, any of the project numbers, you'll get a much more detailed set of information in terms of an abstract, funding, publications that result from that grant, patents, and other kinds of information. So I'm just going to wrap up by saying that we revamped our Tribal Health Research Office website earlier this year. There's a lot of information there, both about our consultation process, about our advisory committee, about the consultations that we've held in terms of summaries of those, the Dear Tribal Leader letters, our consultation policy is posted, news, and funding opportunities. We have a LinkedIn page. If you wanted to sign up, we would welcome that. And if you have any suggestions for how we can improve our website, or if you do decide to go to the report website and want assistance with that, we would be pleased to provide it. Please feel free to contact me or to contact the Tribal Health Research Office. So with that, I will wrap up. I'd be happy to take any questions.
Nick?
Yeah, appreciate the conversation and the updates. I know on behalf of LUMI, we work very closely with NIH when we did vaccine trials. And one of the things that tribes have a lot of concern on is how our data can be used and cause harm. And so when we were part of the trials, that wasn't an easy conversation in our community where people would say, you're volunteering us to be guinea pigs, for a vaccine trial. But we were able to navigate that and work with NIH to where we own our data so that before it's shared, they have to get our permission to use that data. And so I just appreciate that, and I hope more tribes look at that as something to protect their tribal data, and that the data isn't being told in a wrong and harmful way. Data is important. We need to get it out there, but we just need to make sure we're doing it in a respectful way. And so I just want to commend NIH and their leadership on how we had that work at the beginning of COVID and during the trials. I did have a question, and we're bringing this up both with the Portland area and the ECHO program, but with the fentanyl crisis, how many deaths are taking place, it's robbing us of a generation, how they're putting different chemicals in there now. We're losing the battle to fentanyl, just the regular fentanyl. But now we have tranq in many of our communities. It's in every state. We've seen the White House put out warnings about it, and naloxone and those type of things don't work for it. Is NIH doing any type of research or starting research on long-term brain damage due to the fentanyl opiate issues? Is there any talks about that? Because that's what we're really concerned about. We're seeing people that might get heavily addicted, and even when they get clean, they might not appear the same to their family and loved ones. And we need to understand what the long-term effects are. We talk about long-term COVID and studying that, but with this pandemic that we're dealing with, the fentanyl issue, we need to make sure that we're studying that and what the impacts are long-term. Just was curious if NIH has any plans or discussions on that.
The National Institute on Drug Abuse certainly has a number of programs dealing with fentanyl. I can't answer you right at the moment, and I'll be happy to get that information in terms of specific grants. I know NIDA will be coming out very soon with a large, it's called Collaborative Research Effort to Enhance Wellness, or CREW. And that funding announcement will be coming out, I think, next month. And that's a large program. I think it will be of great interest, and it does focus on American Indians and Alaska Natives. But I would be happy to get you more information about the research on fentanyl.
I have a question.
Yes.
So as Councilman Lewis mentioned about opioids, I have similar concerns in Macau. And so I'm just wondering if the NIH is exploring any new trials for different opioid cessation methods like psychedelics or any research like that. Because I think that's a real option. And, you know, I know tribes have used peyote for a long time. So I'm just curious.
Yeah, I would be happy to get you that information as well.
Thank you. Do we have any other presenters? Go ahead, Rachel.
Hi, I'm Rochelle Rollins from the Office of Minority Health, and I realize we have 5 minutes and 2 presenters. I talk pretty quick, but I'm going to hit the high points. So I'm here to talk about the Office of the Assistant Secretary of Health, where OMH sits. So our leader is Admiral Rachel Levine. She's the Assistant Secretary for Health, and OASH oversees the department's key public health programs. We have 10 regional offices, which I'll talk about, the Office of the Surgeon General, the Public Health Service, and of course, public health offices. Previously, Admiral Levine was the Pennsylvania Secretary of Health before joining HHS. Here are the offices of OASH, and there's one I left off, the Office of Women's Health. And I don't know why I did that, but they are our sister office. The newest office here is the Office of Climate Change and Health Equity. Within there is the Office of Environmental Justice. The second bullet is ODPHP. That's where Healthy People lives. We have 2 research offices, Office of Human Research Protection, Office of Research Integrity. We have the HIV/AIDS, OMH. Population Affairs is where family planning and adolescent health is. And of course, the Surgeon General's office has the Commission Core. So we are trending upward in our tribal consultations and listening sessions. And I just wanted to highlight a couple of points here. We did have a tribal consultation prior to the White House Conference on Hunger, Nutrition, and Health. And a framing paper incorporating tribal inputs was received during several listening sessions related to indigenous nutrition, foodways, and food security. Under the second bullet, we had a couple of tribal listening sessions recently. We have a new activity called the HHS Initiative to Strengthen Primary Health Care, brand new. And so this program was launched in September of 2021, and they've had many sessions to collect feedback. At the end of January 2023, there were 2 listening sessions for tribes. And there was an urban Indian organization one in February 2nd. The other 3 bullets, 2 of those are from the Office of Minority Health. We're beginning to do listening sessions for our NOFOs before they come out. And you can see the last bullet is Region 6. They had a community health worker listening session. Now, I do want to say something about, we have the Center for Indigenous Innovation and Health Equity within OMH, and we have a Tribal Advisory Committee attached to that program. And so they've had about 3 meetings so far, and it is the TAC that is within OMH specific to that grant program. A couple of examples of our tribal activities. We do observances. We lead observances. So Native American Heritage Month, a lot of Twitter chats, and we also worked with CDC on the Hear Her campaign. And there's the link for that. Moving faster. So I talked about Healthy People 2030. There are 2 new objectives under public health infrastructure that are new. So if you go to Healthy People 2030, you'll see that. And then within the Office of Women's Health, there's a challenge that is happening. The goal is to provide a platform to inform, the influence policies, educate, develop, promote equity around postpartum. I mentioned that we had the Office of Surgeon General. There's a lot of interest within the stack about the Commission Corps, and they are focused on recruiting officers to serve in Indian country. We have short-term and long-term activities, and then, of course, retention of the officers. We're trying to eliminate any misconceptions of things that may make officers leave Indian country. And so, for example, there's a myth out there about a requirement that officers have to move between agencies and locations. So we're trying to put some clarity around misconceptions. Last slide here is I mentioned that we have 10 regional offices, and these are the dates of the upcoming regional tribal consultations. They happen in the summertime, and you can see the date and the region. I'll stop there. Thank you. Any questions for OASH? No.
Go ahead, Nick.
I feel like I'm hogging the mic a lot, but I do just have I think it's a simple question and maybe more of a general question, but I see equity in a lot of the agencies. We hear it from the administration, and on the definition, it's a good thing. You know, I support fairness and justice and equality, all those things. But when we're underfunded so much in Indian health, in the Indian systems, and we have to compete against one another for the scarce resources that there are available, it's not equity to us. And so what I would ask and challenge in the agencies, equity is good principle to strive to. We know that as much as the agencies want to help with that, some of the funding challenges are outside of their control. So given the reality of the struggle, how can we redefine what equity means in Indian country when we're having to compete against one another? And many of us come from different areas, and we have different needs, and we don't always agree on certain things, and that's okay. But I know one thing is I never want to cause another area or tribe harm, and so I'd like to challenge our agency to look at redefining equity in Indian country, because it doesn't feel like that in so many of the instances we're faced with. I appreciate it, but I just want to challenge the agencies to think more.
I think we heard you. Thank you very much.
I just want to say I want to set up a meeting with her this afternoon.
Go ahead, Will. Just
Huh?
go ahead.
Okay. I want to set up a meeting with you this afternoon on some of your programs, please.
Okay.
Yeah.
Love to.
Good afternoon. I have the unenviable position of going last before lunch, so I will be brief, but hopefully give you a comprehensive overview. Again, my name is Kim Beniquez, and I work in the SAMHSA Office of Tribal Affairs and Policy. And I want to thank you for the opportunity to present this brief overview, maybe even briefer than before. Oh, okay, let's see if I can work this. Okay, there we go. I want to start by saying that SAMHSA respects tribal sovereignty and remains committed to working with tribes, tribal organizations, and urban Indian organizations to improve tribal behavioral health. So this slide is a little bit busy. Just want to point out what I think are the three most important things. That we believe at SAMHSA that behavioral health is essential to overall health, that recovery is possible, and that behavioral health is a priority. And I think as we emerge from the pandemic, more and more people recognize that behavioral health is a priority. So SAMHSA is currently in the process of updating our strategic plan. And here you can see the priorities and cross-cutting strategies that guide our work. And I think they're worth mentioning, even though I recognize that you can read them. Preventing overdose, enhancing access to suicide prevention and care, promoting children and youth behavioral health, integrating primary and behavioral health, and using data and evaluation to make decisions. And then our cross-cutting principles are equity, and I appreciate your comment, Councilman Lewis, workforce, financing, and recovery. And pictured here is our Assistant Secretary, Dr. Delphin Rittman, who will be presenting tomorrow, along with our Director of Financial Resources. So I mentioned that I work in the Office of Tribal Affairs and Policy, and that office serves as the point of contact within SAMHSA for tribes, tribal organizations, and urban Indian organizations, basically everybody, regarding tribal behavioral health. And here we have listed our website. We've been working hard to improve and update our website and to be very transparent with our work and list everything as much as possible on our website. So I encourage you to check that out. Our agency, like the others within HHS, has regional directors and assistant regional directors in each of the 10 HHS regions across the country. And these regional offices are a part of SAMHSA leadership and work to advance the agency's mission. And we really rely on them to have kind of a pulse check and have all the details of their respective areas and to provide resources to individuals in those areas. Now I want to talk briefly about our SAMHSA programs that are only eligible to tribes and tribal organizations. The first of those is our Tribal Opioid Response Program, or TOR as we refer to it, which originated in fiscal year 2018. The purpose of this program is to address the opioid crisis in tribal communities by increasing access to culturally appropriate treatment. This program has a lot of flexibility for tribes to provide prevention, treatment, and recovery services that are most needed in their community. And the program also allows services for stimulant use and misuse. And you can see the map that depicts the locations of the grantees. And this just is a graphic of the number of awards that were made each year since the program inception and the amount of the award in total. The second program is Native Connections, and the purpose of this program is to prevent suicide and substance misuse, reduce the impact of trauma, and promote mental health among tribal youth through the age of 24 years. There is a current notice of funding opportunity for Native Connections. Over $15 million will be awarded, and applications are due May 15th. So I know that's not too far from now, but it's been posted, I believe, since March. And then the third program is our Circles of Care program. This aims to develop a community-based system of care for children with mental health challenges and their families. And again, the map depicts the locations of the Circles of Care awardees. And again, there is an open notice of funding opportunity for Circles of Care. Over $5 million will be awarded, and applications are due May 5th. I'd like to switch gears and talk briefly about our technical assistance resources. The SAMHSA Tribal Training and Technical Assistance Center and the National American Indian and Alaska Native Technology Transfer Centers for Addiction, Prevention, and Mental Health provide training and technical assistance specific to working with tribes and tribal citizens in the behavioral health arena. I want to mention that we also have a notice of funding opportunity for an American Indian Alaska Native National Behavioral Health Center of Excellence. So we'll be transitioning from our technology transfer centers to a center of excellence, which we believe elevates that. There will be one award made for up to $1.5 million, and applications for that are due May 26. Our Opioid Response Network, or ORN as we refer to it, we use a lot of acronyms, just like most government agencies. The ORN is designed to respond to local needs by providing free educational resources and training to basically anyone that's interested, individuals, states, communities, tribes, tribal organizations, urban Indian organizations. You do not have to be a SAMHSA grantee to take advantage of these services. They provide resources and training on prevention, treatment, and recovery of opioid use disorders and stimulant use. I also want to talk a little bit about our Tribal Technical Advisory Committee. We refer to that as TTAC, again, more acronyms. Our TTAC is comprised of 14 elected or appointed tribal leaders from federally recognized tribes. We meet at least quarterly with our TTAC. In fact, our next meeting is next Tuesday. And we rely heavily on our TTAC to guide our work and to challenge us when we don't meet expectations because we know lives are at stake. We do have vacancies on our TTAC. You can see them listed here. So if you or anyone you know is interested, please connect with me. We'd love to have a full complement on our TTAC. I'd like to share updates about our 988 Suicide and Crisis Lifeline. As you likely know, in July of 2022, SAMHSA switched from a 10-digit to a 3-digit code to access the National Suicide Prevention Lifeline. Since this time, SAMHSA has provided funding to states and tribes to help build the crisis response infrastructure. And SAMHSA will soon release another round of funding for tribes and tribal organizations. It's not posted yet, but it should be soon. Throughout our process of implementing 988, we did partner with tribes. We understand there are very unique challenges in implementing 988 in Indian country. We held listening sessions, and we established technical assistance resources specifically for tribes regarding the 988 and crisis response system. This is a work in progress. When 988 was implemented in July, we saw that as a starting point, not an ending point. So this work will continue. As you may have heard, we're in the process of updating the National Tribal Behavioral Health Agenda. For those of you not familiar with the TBHA, it's a document that was created in 2016 through a comprehensive process that included tribal leaders, tribal organizations, federal partners, and other stakeholders. And it includes a cultural wisdom declaration written by tribal leaders. So the rationale behind the update is based on feedback that we received. Tribal leaders, including our TTAC delegates, felt that an update was needed since the COVID-19 pandemic basically changed all aspects of our lives. You can see here a listing of our meetings to date. This is going to be a long but comprehensive process. And we will be presenting about the TBHA and the update process at national tribal meetings next month. If you're interested in being part of this process, please connect with me. We'd love to include you. So that concludes my presentation. Thank you again for the opportunity to speak. And I guess it's lunchtime, and if nobody has any questions. I do have slots open in the afternoon if anybody's interested. I do have some meetings scheduled, but I do also have open slots.
Yeah, I would like to be scheduled.
Shauna, did you have a question? Oh, okay. Okay, no other questions. So we're on lunchtime and then from 2 o'clock to 5 o'clock there will be one-on-ones if you made arrangements for those meetings. And tomorrow we'll start at 8:45, and we need to make sure that we start at that time so we can try to get through the agenda as easy as possible. And tomorrow I'll be following the HHS process, and I'll remind everyone the order of the way that the meetings are supposed to run is tribal presidents, chairpersons, governors, or chiefs are first to speak. And then it goes to the vice presidents, vice chairs, lieutenant governors, second chiefs, and then on to the elected appointed officials, and then last in line would be the designated tribal officials. So anyway, we got to follow that order. It's a consultation policy that we need to follow. Thank you. So we'll break for lunch, and if you're not doing one-on-ones, so we'll see you tomorrow. Go ahead, Jen.
For the one-on-ones, do we wait in here then? And they come get us? What is that process?
Produced by the U.S. Department of Health and Human Services.